Introduction background. The following research is a narrative review of upper cervical procedures serving to facilitate understanding and awareness of upper cervical chiropractic care. It's designed to discuss safety, efficacy, common misconceptions, and research so that providers, students, and the general public can make informed decisions regarding utilization and referrals for upper cervical chiropractic care. Upper cervical, meaning upper neck, techniques have the same goal in mind with different approaches to achieving the same end. They adhere to the same theory in that primary chiropractic subluxation exists in the upper cervical spine. All of these techniques have methods to check before and after intervention to assess whether it was successful or not. While there is plenty of research on upper cervical care, much more is needed. This narrative reviews much of what exists, regardless of the quality of the research, which includes non-indexed and/or non-peer-reviewed sources. The paper presents most of the upper cervical techniques, similarities, and differences of them. Only 1.7% of chiropractors practice upper cervical techniques, which makes it understandable that it's so little known. The origins of upper cervical chiropractic techniques have been around since B.J. Palmer, the developer of chiropractic, introduced the HIO method in 1931 at the PSC Lyceum. The 1934 text, The Subluxation Specific, the Adjustment Specific, established the foundation for the articular model of radiographic analysis, while Dr. A.A. Wernsing contributed to the upper cervical work with the orthogonal base radiographic analysis in his book, The Atlas Specific. Now, the difference between the articular model and the orthogonal model have to do with whether they're looking at the joint alignment in the upper neck or if they're looking at how the head sits on top of the top bone in the neck, which is atlas, which sits on the neck. And these techniques can be categorized into, the major techniques can be categorized into either an orthogonal technique or an articular technique. The upper cervical techniques that fall under the articular model include knee chest, toggle recoil, and Blair. The upper cervical techniques that fall under the orthogonal techniques include Grostic, Nuka, orthospinalogy, atlas orthogonal, and advanced orthogonal. Upper cervical anatomy. The theory that the primary misalignment or chiropractic subluxation exists in the upper cervical spine has been around for over 70 years. The upper cervical spine or upper neck consists of top two bones in the neck and where the top bone articulates with the skull, the occiput. This is called the craniocervical junction in newer medical and chiropractic literature. This area of the spine is unique compared to the rest of the spine for several reasons, ranging from anatomical shape, neurological structures, and complex ligamentous systems. Neurovascular structures and cerebrospinal fluid also play a part in this area of the spine. The chiropractic vertebral subluxation has been defined by many organizations and also by those who founded and developed the profession. The World Health Organization defines it as a lesion or dysfunction in a joint or motion segment in which alignment, movement integrity, and/or physiological function are altered. Joint surfaces remaining in contact, which may influence biomechanical and neural integrity. Neural meaning nerves. This definition is for a chiropractic subluxation, not a subluxation defined by the medical profession, which is very different. Medical subluxation is where there is ligament or joint laxity due to a severe injury, making the joint unstable, but not completely dislocated. The upper cervical procedures paradigm is such that it looks at the occipital-atlantal joint complex, meaning where the head articulates with the neck, and looks at the function and all of its substructures and is analyzed as such, making it different than traditional chiropractic techniques. Upper cervical techniques differ slightly in their analysis and application, but all focus on an exam to determine the presence of chiropractic subluxation, then a detailed radiographic analysis to confirm presence of subluxation, and also to determine how their unique subluxation and alignment need to be achieved. Most techniques limit their intervention to the craniocervical junction, except for the Blair technique, which goes down to C4. Theoretical physiologic mechanism. Leg length inequality or abnormal load bearing, joint mechanoreceptors. So now what happens in the upper cervical spine because of what's going on with the load bearing joints and the reflexes that happen with muscles and posture, a misalignment at the top of the neck in the craniocervical junction can distort the hips, creating what appears to be a leg length inequality. Now, joint dysfunction creates symptoms through this disafferentation process. Disafferentation just means abnormal nerve flow or input into the brain, and then that feedback loop back to the muscles controlling posture. Now, correcting this modulates the nervous system, which is important. Dentate ligament cord distortion hypothesis by Dr. Grostic in 1986. A research article that shows an MRI with cord distortion from an upper cervical subluxation complex, which I'm very interested in and would love to do a review in the future as well. Recent research shows altered cerebrospinal fluid flow and blood flow dynamics in the craniocervical junction. Assessments for care. Determining the presence and absence of the chiropractic subluxation or manipulable lesion has been a point of controversy. While some evidence exists of exams to indicate the presence of subluxations, some are stronger than others, and some research say there needs to be more research done. Some exams indicate when to perform the adjustment. Some exams indicate where to make an adjustment or a correction, and in which direction. Some of these examples include leg length inequality, thermography, palpation, posture, X-ray line marking. Symptoms are not used to dictate patient care, but are used as outcome measures. Table 1 shows which techniques use which. Many upper cervical techniques have certifications and postgraduate work or seminars in order to become qualified to perform the techniques. A misconception of upper cervical practitioners is that they focus only on the upper neck. While this is where the intervention is given, many providers analyze the entire spine, and the intervention itself, given in the upper cervical spine, affects alignment of the entire spine. Upper cervical practitioners are also focused on determining if an intervention is necessary on a given visit, and whether the intervention was successful with an examination after the intervention. Patients are not adjusted on every visit, only after being examined on that specific visit, and the patient is found to need an intervention is that intervention given. If the patient does not need an adjustment or intervention on that visit, it is commonly known as holding their adjustment or holding their alignment. Now, different kinds of assessments, one being palpation. It includes assessing the joint movement of the upper cervical spine and muscle spasms and tenderness of the upper cervical spine. Another assessment being functional leg length inequality. This is analyzed by laying the patient down on the stomach or on the back to analyze what appears to be a short leg, which is not structural but functional in nature. It can be called a contractured leg, and this is due to pelvic obliquity resulting from reflexive balancing due to neurological insult in the upper neck. Anatomical inequality may interfere with this measurement. There are several ways to measure an anatomical short leg to rule this variable out. Research shows high inter-examiner reliability in leg length testing. Another assessment being thermography. This type of measurement is used in pattern analysis developed by B.J. Palmer in the 1930s. Paraspinal thermographic readings are used as an indirect function of the nervous system, used before and after the upper cervical procedure. It has excellent inter and intra-examiner reliability in the research. One study shows improvement in bilateral thermographic readings correlated with an improvement in heart rate variability. Another assessment being posture asymmetry, used mainly by orthospinology and NUCA to visualize structural changes in posture pre and post correction. NUCA developed the anatometer to measure posture in the coronal and transverse planes. So meaning twisting of the body you can think of, and misalignments from side to side you can think of. Some models have weight scales under each foot to measure different weight differentials. The GSA is another tool that measures standing posture. Another assessment tool being radiography. All upper cervical techniques use radiographic analysis to guide them in correcting misalignments. The analysis allows for each individual patient to receive the most precise correction possible. Radiographs are taken in all three planes to get a three-dimensional measurement or direction and degree of misalignment for all orthogonal models and some articular models. Blair, however, takes a protracto view, which comes in at a diagonal almost through the eye to look at the opposite articulation between occiput and atlas, between the head and the neck. Blair also uses a stereolateral to look at facet alignments below atlas. X-rays are not performed on every visit. Research shows that misalignments are predictable in the direction that they re-misalign. So you don't need to take an X-ray to look at how the bones have misaligned on every visit, because we know how they're going to misalign. Several factors are used to decrease X-ray exposure: aligning X-ray equipment, decreasing X-ray port size, meaning where the X-rays come out of the tube, specialized grids and filters, and shielding all decrease X-ray radiation. The safety and ethical dilemma of radiation exposures is an entirely different subject that we won't get into here. Suffice it to say that some believe X-rays should only be taken when trauma is suspected, not for just subluxation evaluation. Each technique have standards for taking radiographs. NUCA has gone as far as developing standards of care and practice guidelines that are continually updated regarding radiographic guidelines. And once again, all techniques, upper cervical techniques that take radiographs, have guidelines on how to take proper films so that the analysis of the misalignment can be done correctly. There's a lot of information in this section that I'll let you read yourself. Now, contrasts of upper cervical techniques. Biggest difference in upper cervical techniques are the difference, again, between orthogonal and articular model. Articular model typically does not obtain post films as orthogonal does. Differences in radiographic technique and adjusting protocols are unique to each technique, all with the same goal in mind, in the end, to bring proper function and alignment to the upper cervical spine. Adjustments are done by instrument or by hand. Orthospinology uses a handheld instrument that adjusts the atlas bone and the upper cervical spine, the craniocervical junction. Atlas orthogonal and advanced orthogonal uses a table-mounted instrument. Blair, knee, chest, toggle, recoil, and NUCA and Grostic are all done by hand. Many providers have patients rest 20 minutes or more after adjustments in hopes that they hold their alignments longer. A symptomatic reaction paper is referenced here, where 83 upper cervical doctors following 1,090 patients were studied on safety and efficacy with very, very positive outcomes, which we have done a review on that, so you can find that video where we go very much in depth to that. Upper cervical chiropractic research. A study with 50 patients, pilot study in a hypertension medical journal, where 25 patients were adjusted, 25 received a fake adjustment. The results here were that the patients receiving care had their blood pressure decrease as if they took 2 antihypertensive medications. The changes in blood flow hypothesized in this previous study was investigated more using phase contrast MRI, resolution of migraine symptoms with changes in blood flow was found in a study by NUCA, the National Upper Cervical Chiropractic Association. More hemodynamic and hydrodynamic studies are currently in process. Research correlating degree of improvement on X-ray alignment correlating to patient outcomes has been performed, but we do need more studies showing this. Upper cervical technique case reports. Several case studies by Gleberson describe significant clinical benefits and improvements in quality of life. Case studies are necessary to justify use of limited research resources required for conducting larger clinical studies. Case studies in the literature include the following: Parkinson's disease, multiple sclerosis, seizure disorders, headaches and migraine, seizure and migraine, fibromyalgia, chronic fatigue syndrome, scoliosis, blood pressure, and several others. Limitations of this paper. This paper is a narrative review describing upper cervical techniques, not an exacting review of all the available literature. There's little high-quality research citable from PubMed indexed journals. Some research articles are non-indexed and non-peer reviewed. Again, this being a review of techniques, more research definitely is needed, but we need that financial backing in order to be able to do so, which hopefully will be soon in the future. Hi there, I'm Dr. Kevin Leach here with the Chiropractic Deep Dive Podcast, bringing you the most important research and information on conservative primary spine care, upper cervical chiropractic care, and traditional chiropractic care. I'm really trying to bring value with these, so I'd appreciate commenting on the videos, hitting the like button, and sharing them with as many people as you can. You never know who might need to see it. And consider subscribing to the channel so you can see all the other episodes and videos coming out. Thank you so much. I truly appreciate your support.